Health Center, the Ottawa Hospital, University of Ottawa, Canada. She's giving a lecture about radiology pathology correlation, case-based review. Thank you.
Thank you very kindly for the kind introduction. I thank everyone in the audience for being here this morning again after yesterday's intensive lectures. And once again, I thank Rasha, Merit, Professor Hisham Al-Ghazali, everyone on the dais here for having me. And without any further ado, since morning we have seen a whole bunch of lectures related to these high-risk lesions from all the gurus of breast imaging. So we have heard Dr. Tabar, we have heard Jessica, we just heard Professor Iman, and it may all Shahia. So you may, sorry, I'm not good with names yet, but slowly, but surely we'll get there, okay? Now, this lecture may almost seem like a repeat, but this was created a few years ago as a collaboration between University of Ottawa and University of Toronto with radiology and pathology. Dr. Anna Marie Mulligan, who is the assistant professor at the University of Toronto, she was the one who provided pathology lectures, slides here, and all the inputs related to it. Because our constant frustration is, what do I do with these pathology results? Why am I not getting a definitive answer from pathology? So to understand their perspective, so that we can give appropriate recommendations, we thought this would be the best way to make this understanding for us. So what is the objective of this talk? Whenever we do any biopsy, our role is establishing radiology pathology concordance, identify high-risk lesions, which means despite the pathology showing that there is no cancer, we have to identify whether anything needs to be done further and recommend appropriate management in the form of repeat biopsy, surgical excision, or just say that the patient is all right, she can go home, she can come back after 1 year, or finally, keep a close eye on the patient, okay? So these are some of the options available. But when do we use our trump cards is the question, okay? Suspicious abnormalities seen on imaging definitely require histopathology correlation, that is a biopsy. After that, it is the radiologist's job to decide whether there is imaging and histopathology concordance or discordance. And then it is our job to recommend further management. Remember, it is not the clinician, it is not the referring physician, patient definitely not, and many times it is not the pathologist's role. Therefore, the responsibility lies on us. These are some of the options we have: return to routine screening, short interval follow-up, or repeat biopsy. So whenever you're looking at the histopathology report, you ask yourself these questions. I have made a set of 5 cases here before we embark on the actual lesions to understand how we do this process. This is case 1. Patient presents with a new onset palpable lump in the right breast, okay? We see a partially circumscribed mass with some peripheral speculations. On ultrasound, it corresponds to what looks like a partially circumscribed hypoechoic mass, okay? What do? We did an ultrasound-guided core biopsy with a 14-gauge needle, which demonstrated a benign intraductal papilloma. The question we should ask when we see this pathology report is, are the imaging features concordant or discordant? And what should be the further recommendation? Considering the appearance on the mammogram with the peripheral speculations, we decided that the histopathology features are not concordant. We should repeat a biopsy with at least a 10-gauge vacuum assisted so that we have a bigger chunk, or send the patient for a surgical excision biopsy. In this case, the final histopathology came as invasive papillary carcinoma. Okay, another case. There were new amorphous microcalcifications seen in the upper inner quadrant of the right breast. Stereotactic vacuum biopsy showed a whole plethora of pathologies. Columnar cell change, sclerosing adenosis, PASH. Now, one has to decide, are any of these high risk? Can any of these turn precancerous or cancerous? So does this need to come out? Okay. Are the imaging findings concordant with the histopathology, and do we need to do something more? This is considered concordant. Yes, columnar cell change, sclerosing adenosis, PASH, everything can look like this. And this is definitely not a high-risk lesion. Therefore, patient was recommended to go back to routine screening. Here's another case. This is a dense mammogram, but the patient had a new onset palpable lump. Ultrasound correlation corresponded to this irregular, hypoechoic, sinister-looking mass in the upper inner quadrant of the right breast. What did we do? We did an ultrasound-guided core biopsy with a 14-gauge needle, and the histopathology said stromal fibrosis. Now look at this lesion. It is book picture lesion like a cancer, but the histopathology report says stromal fibrosis. Can this be concordant? No. What should we do? Repeat biopsy with vacuum-assisted 10 or at least 12-gauge needle. Final diagnosis was invasive ductal carcinoma. Yet another case. I'll show you 5 cases so that you get a practice of how this process is done. Okay? We saw coarse calcification with a circumscribed mass and peripheral spiculations. Biopsy was performed using a 14-gauge needle. Calcified fibroadenoma and radial scar was the histopathology diagnosis. Is it concordant? Should we do anything else? Well, it could be concordant because there is a radial scar, peripheral spiculation. There is a coarse calcification. It could be a fibroadenoma. But given that there is a radial scar, we recommended surgical excision. Final diagnosis was in keeping with fibroadenoma and radial scar. This was not upgraded further, okay? So sometimes that can also happen. Here's another case. Although this is an oval mass, look at the margins. They look so suspicious. Therefore, ultrasound-guided core biopsy was done. It showed fibroadenoma. Is it concordant? No. Repeat biopsy with vacuum-assisted 10 or 12-gauge needle. Again, the final diagnosis showed fibroadenoma. At this point, we said, keep this patient under surveillance. 6, 12, and 24-month follow-up. The fibroadenoma remained stable. Sometimes, as the fibroadenoma starts involuting, the margins start getting irregular, or we start seeing coarse calcifications. Therefore, this is considered concordant. Another similar case, corresponding to a well-circumscribed mass in a heterogeneously dense breast, we saw this mass. Biopsy was in keeping with fibroadenoma, okay? This was considered concordant considering the lesion is oval, relatively circumscribed. 6, 12, and 24-month follow-up was recommended as per protocol, okay? Patient did not follow up. What happened later was, 2 years later, she came with an increasing palpable lump, and this time the biopsy was in keeping with invasive ductal carcinoma. So we asked to review the previous histopathology slides, and this time the pathologist said, probably it was not a fibroadenoma, it was stromal fibrosis. So what exactly is this stromal fibrosis? These and some other questions is something that we're going to look at in the next 20 minutes, okay? What are the reasons for false negative diagnosis? Sampling error, failure to recognize and act on radiology pathology discordance, and lack of imaging follow-up after a benign biopsy result, okay? Some of the lesions which are associated with upgraded excision, which means the first pathology may show us some form of precancerous or atypical lesion, and after surgical excision, it may show some form of cancerous or precancerous lesion. So this is those lesions: flat epithelial atypia, atypical ductal hyperplasia, lobular neoplasias, radial scar, papillary lesions, juvenile papillomatosis, fibroepithelial lesions, stromal fibrosis. Okay, so your first biopsy with a 14-gauge needle, if it shows any of these results, be more cognizant that you want to review imaging properly again and give appropriate recommendations. The histopathology, which are associated with false positive, which means it is indeed benign, but it looks like a cancerous or a precancerous lesion. Often it happens with things like sclerosing adenosis and PASH. So just a quick look at the chain of ductal diseases. Single normal cells, single duct. Sometimes there is benign hyperplasia. Then it shows atypia, ductal carcinoma in situ, and then there can be micro-invasion, and full invasion. So this is how disease progresses in the breast pathology. Here's a case of a mammographically detected pleomorphic microcalcifications, okay? These columnar cell changes typically, and this was in keeping with columnar cell lesion, these typically happen in the 4th and 5th decade of life. The calcifications are round, non-branching, and there are samoma bodies, as they call it, okay? As per the pathologist, there are enlarged TDLUs in this case, okay? Now, if you look, now I'm not an expert, but from even eyeballing, we can see in columnar cell change, everything is pretty uniform. In columnar cell hyperplasia, things get a little riggedy-raggedy there, okay? And in atypia, flat epithelial atypia, everything gets even more disorganized. There is cytologic atopia. So what is the significance of this? There is, in fact, very limited data about what should be done with this. They are considered to be non-obligate, indolent precursors. Should we excise them? No, we don't really know. However, based on various articles, the recommendation is if there is columnar cell change without atypia, we can leave it alone, okay? What about atypical ductal hyperplasia? If there is a result of atypical ductal hyperplasia, what will you do? That is typically seen when there are microcalcifications which are fine, branching, linear branching, pleomorphic, okay? Now, when you ask the pathologist, how do you differentiate between ADH and DCIs, typically low-grade DCIs? They will tell you it is a quantitative and qualitative criteria, which means if there are 2 duct spaces, and if more than 2 millimeters of it is completely filled, then they call it a DCIS instead of ADH. Now, from this itself, you can understand it really depends on which part of the lesion we have sampled, whether they are going to get that part or not that part. As we see in these 2 ducts here, there is proliferation, they're completely filled, and they're completely distended. So what is the management recommendation? What we know is, when we do a 14-gauge core needle biopsy, there can be an underestimation ranging from 11 to 88%, which means if this patient goes ahead for surgical excision, there could be a wide chance that this may upgrade to DCIS. Therefore, if we see pleomorphic microcalcification, the recommendation is at least do a vacuum-assisted biopsy with 10 or 11 gauge. In this case, there is lower underestimation rate. The underestimation rate ranges between 8 to 39%, okay? But even with 100% excision of the lesion, there is still a 8% upgrade rate, okay? So one has to be cognizant of this fact. Therefore, if there is ADH, what do we recommend? Can we recommend excision right away? There are 2 schools of thoughts about it currently. But if there are associated risk factors, the patient is high risk, there is any personal history, then we recommend excision. What about lobular neoplasias? These are often seen as serendipitous discovery on many of our biopsies, okay? We were not expecting to see a result of lobular hyperplasia or lobular neoplasia, and there we have the diagnosis. And sometimes it can be detected as microcalcifications on the mammogram or non-mass enhancement on MRI. As we see this, it can look quite sinister. On this MRI, almost 1 quadrant of the breast showed asymmetric non-mass enhancement. So therefore, we worry if there is any underestimation. What is it that we need to understand here? What we need to understand is, in lobular neoplasias, they have atypical lobular hyperplasia or LCIS. How do they differentiate between the two? When the TDLU is completely filled with these cells, they call it ALH, and when it gets distended, they call it LCIS, okay? Now, within this LCIS, there are 2 subtypes, pleomorphic and classic. If the diagnosis shows classic LCIS, then complete excision is required. So for us, as radiologists, these terms should make sense. Like, we should understand when we have to recommend an excision. If it is just lobular hyperplasia with no, where the pathologist has not described, whether it is LCIS, pleomorphic, classic, then we can't give those recommendations. Management depends upon coexisting high-risk lesions such as ADH, if there is rat path, discordance or concordance, whether there is an associated mass, or there are some variants. What about radial scars? We had a beautiful lecture this morning by Dr. Tabar on radial scars. These are usually seen as architectural distortions with long spicules, and they are typically called black stars. Why do we worry about them? By itself, radial scar is not considered bad, but its associations are bad. His friends, the people the radial scar hangs out with, is bad. What does radial scar hang out with? DCIS, flat epithelial atypia, atypical ductal hyperplasia, papillary changes, lobular neoplasia, and sometimes tubular carcinomas. Okay, therefore, we worry about underestimation. Okay, now there can sometimes be a little bit overlap between radial scar and tubular carcinoma on 14-gauge core needle biopsy. And therefore, if you have done a 14-gauge core needle biopsy and the histopathology shows radial scar, then we recommend a surgical excision, because the upgrade rate to ADH, DCIS, ALH, or LCIS is about 28%. And in some cases, some studies have also shown that the upgrade to a tubular carcinoma can be as high as 40%. Therefore, if at the first pathology report shows radial scar, either you repeat the biopsy with a 10-gauge vacuum-assisted device. A minimum of 12 samples should be obtained. If that is completely negative, it is okay to follow the patient. If the patient is not willing to have a repeat vacuum biopsy, surgical excision biopsy can be recommended. Okay, what about papillary lesions? We had this wonderful lecture in detail about papillary lesions. Okay, so I'll speak in short here. They can come across as circumscribed masses or microcalcifications, complex solid cystic masses on ultrasound, and clinically often they present as spontaneous bloody or watery nipple discharge if there is a central papilloma, but peripheral papillomas may be completely asymptomatic. Okay, so what is the confusion here? There are many subtypes, and it entirely depends on which part of the lesion we biopsy. Therefore, the pathologists are often reluctant to give us a final diagnosis based on our core biopsy samples. It is difficult for them to make out whether there is pseudo-invasion or real invasion. Okay, so what is the management recommendation? If an intraductal papilloma shows atypia, the recommendation is to excise. But if the intraductal papilloma is benign, that's where all the trouble starts. Okay, it is controversial because of the various worrisome reasons. So some of the articles recommend that if the patient is symptomatic, okay, spontaneous bloody or watery nipple discharge, patient is above the age of 50, lesion size is more than 1 centimeter, and it has a higher BIRATS category, 4B, 4C, then you either upgrade the biopsy to 11-gauge vacuum-assisted or recommend a surgical excision biopsy. What about juvenile papillomatosis? These are rare high-risk lesions seen in younger women. Oftentimes, these young women will come with what looks like a cluster of microcysts. Okay, but when you scan through the breast, you will not find any cysts anywhere in the breast. Okay, hypoechoic masses filled with multiple cysts, microcalcifications may or may not be seen. Okay, on histopathology, it is quite diagnostic. What is the recommendation for these? They can be associated with carcinomas in up to 15%. Therefore, surgical excision is recommended. Okay, what about fibroepithelial lesions? Now, they are getting very confusing with TNBCs, as we saw in the lecture by Dr. Liang. But just plain simple fibroadenomas, whether it's a fibroadenoma, it's a phalloides, or it is a malignant phalloides, that needs to be determined. Okay? Fibroepithelial lesion by itself, a fibroadenoma also has variants. It can be the classic type, or they can be increased cellularity, and then it gets confusing with phalloides tumors. Okay? Therefore, assessment between cellular fibroadenoma versus benign phalloides is harder for the pathologist, and so is the differentiation between benign phylloides and malignant phylloides. So what is the recommendation? If you do a biopsy and it just shows benign fibroadenoma, you don't have to do anything, like recommending a surgical excision. Okay, if it looks like a classic fibroadenoma, then the recommendation is 6, 12, 24-month follow-up. But if the histopathology shows cellular fibroadenoma, surgical excision is recommended. If it is a benign phylloides, even then surgical excision is recommended. The reason being, benign phylloides also are associated with 20% local recurrence and 1% mets. And borderline phylloides, 45% local recurrence, and malignant phylloides with 65% local recurrence and 30% lung metastasis, okay? So, surgical excision recommended for fibroadenoma with cellular stroma, or if the histopathology report shows fibroepithelial lesion, fibroadenoma versus phylloides tumor, or clearly borderline or malignant phylloides tumor. What about sclerosing adenosis? They often are seen as microcalcifications on a mammogram, or they may be seen as asymmetric non-mass enhancement on MRI, and it can be quite confusing, okay? But they are not high-risk lesions. Therefore, surgical excision is not recommended. These are considered proliferative breast disease. Overall risk of malignancy, relative risk is 1.7 to 2.5, okay? They account for false positive diagnosis at pathology, and they may mimic cancers like tubular carcinoma or radial scar at pathology. All that is recommended in these cases is follow-up, okay? Almost there. What about PASH? PASH can be an incidental diagnosis, or they can be seen as microcalcification, or even well-circumscribed masses like a fibroadenoma. You biopsy a lesion considering it could be a fibroadenoma, and the histopathology report comes back as PASH, pseudoangiomatous stromal hyperplasia. Is it a high-risk lesion? It is not considered a high-risk lesion, okay? It's incidentally found sometimes on targeted lesions. They often recommend that only a follow-up is required if we see a PASH. However, occasionally we have seen PASH grow very fast, as big as a phylloides tumor, okay? And in those cases, they have been surgically excised. Now, last but not the least, stromal fibrosis. What is this stromal fibrosis, and what should we do if we get a diagnosis of stromal fibrosis? So what happens is, when there is any tumor, typically a malignant lesion, there is surrounding desmoplastic reaction, okay? Sometimes this desmoplastic reaction can occur surrounding fibroadenomas also, or surrounding benign lesions also. And therefore, it looks like a spiculated mass, okay? But the center of the lesion may have cancer, and the surrounding region may just have desmoplastic reaction. We cannot make the difference based on ultrasound. Our needle almost seems like it is through the lesion, but it is only through the desmoplastic reaction and not through the center of the lesion. Therefore, if you get a diagnosis of stromal fibrosis, then we need to do something further, okay? There have been a few studies, and our own data from the Ottawa Hospital showed that whenever there was a diagnosis of stromal fibrosis, there was a 8% incidence of upgrade to some form of malignancy, which means there was a cancer in the center, and in the surrounding area, we only saw desmoplastic reaction. If the imaging features are concerning, like a spiculated mass, then you recommend a repeat biopsy with 11 gauge or 10 gauge vacuum assisted biopsy. At the second biopsy also, if it is negative, then you may choose to follow up. But despite the second biopsy, if you're still concerned, then don't hesitate to ask for a surgical excision biopsy. So in a nutshell, when you see these odd diagnoses, what are the recommendations you should give? Every time you give a recommendation, there has to be histopathology and imaging correlation. If there is columnar cell change, follow up to ensure stability. If it is associated with flat epithelial atopia, surgical referral to consider whether she needs a surgical excision. If there is atypical ductal hyperplasia, we are currently recommending surgical excision, okay? But this remains an area of controversy. Some people are saying now that it is okay to follow atypical ductal hyperplasia. What about ALH, and classic LCIS, the recommendation is 6, 12, 24-month follow-up. But for pleomorphic LCIS, the recommendation is surgical excision. Radial scar, if you have done the first biopsy with 14-gauge needle, then you can recommend a surgical excision, or a upgraded biopsy with a vacuum. Papillary lesions, depending on the appearance, if it is a benign papilloma, depending on the other factors, you recommend surgical excision. Juvenile papillomatosis, definite surgical excision. Fibroepithelial lesions, if it is a cellular fibroadenoma or phalloides tumor, surgical excision. Stromal fibrosis, repeat biopsy, correlation with imaging findings, and depending on the imaging findings, you recommend a surgical excision. Sclerosing adenosis and PASH, follow-up to ensure interval stability. So in conclusion, core needle biopsy with 14-gauge, standard of care for breast lesions. Following biopsy, imaging pathology concordance or discordance needs to be established. And depending on that, we recommend whether we need a repeat biopsy, or is it okay to send the patient back to routine screening, or we need to have a short interval follow-up, okay? Decisions are about real patients. It affects their welfare, their families, and their lives. In high-risk lesions, things are at stake because, God forbid, if you miss something which was early enough, and 1 year or 2 years later, the patient comes with a node-positive cancer, she has missed the boat despite of seeing the doctor in time. Underestimation of malignancy is a missed opportunity for cure and hence overall survival. And over-treatment, unnecessary surgery, that is also unnecessary harm that we cause to patients. So remember this oath that each and every one of us took when we became doctors. First, do no harm. Okay, thank you for your kind attention.
Thank you very much, Professor Shilpa. And now we open the floor for discussion. We just have only 5 minutes. So we'll start in, I don't know if Dr. Tabar is online or not. Is he online? حد عارف؟